All right, welcome to the Pecha Kucha session. So this is going to be a very energetic session. I don't think anyone will fall asleep, even if you tried. So I'm Yeong Cheah. I'm a professor at University of Oxford, a bioethicist at the Mahidol Oxford Tropical Medicine Research Unit, and a steering committee member of the GFBR. Okay, the Pecha Kucha session will run like this. So the speakers have all been lined up, so get ready. Ready, get set, go. So the slides, the people with power over there will be advanced automatically every 20 seconds. So speakers will have no autonomy in terms of advancing their slides. So it's a very rapid fire session so that we get to know each other or as many people as possible in one short session. Unfortunately, no questions allowed at this session, but you can of course talk to people after the session, during the tea break. So speakers, when you come up, okay, when you're ready, say start, and then go, okay? All right. Okay, so we shall start. Now, I'm gonna start with the first speaker. All the speakers, can you get ready to jump when I call your name? All right, the first speaker is Margaret Kaseje from Kenya.
So I'm going to talk about a small case study from Kenya, and this involves a period during COVID-19 when there was a global impact on rural communities as well as international communities. And the question that we are going to be looking at is accessibility, ensuring that community members, regardless of their location, socioeconomic status, are able to take part in a pandemic. Now, emergency situations when people are despaired, people are afraid, how does one involve a community member in obvious distress and looking at what they can do in terms of prioritizing their research? There are ethical challenges. For instance, we should not do harm. We should look at the wellness of the community, no stigmatization. With the increased risk of COVID transmission, what about PPEs? What about meetings? What about dialogue? Who do we involve as stakeholders? It's important to involve everybody. We try to involve community leaders, health volunteers, and healthcare providers, and brought them together. We looked at vulnerable groups, the elderly, the children, and those with pre-existing conditions, and brought them together. How did we sample them? We looked at the community's situation, and we made sure that each stakeholder was engaged in a different group setting. We talked with them in-depth, engaged them, looked at questions. What were the priority questions that they had that they wanted to be looked into? We, of course, had conflict of interest. There were many community members who thought that other things should be looked at. What about our safety? How do we get involved? What about out there in the capital? What are they doing? Why is this thing happening to us? What we did, we came together and tried to resolve these conflicts. So we had dialogue, open dialogue, to build trust so that we tell each other, we are not here to harm you. We want to engage you. It was an iterative process. We engaged community members and stakeholders from the start. We walked with them slowly to get them on board. Communication was very, very important. Timely communication. This is what is happening about the COVID. This is where it has reached. We looked at miscommunication that could lead to confusion, fear, or mistrust. As researchers, we had to consult with community leaders and be open and say, we are not keeping any secrets from you. This is the stage where it has reached. We had to look at the complexity of decision-making in the community and reach a consensus and see what resources were available for us to move together. We were not comfortable. we were always asking questions. We were not assuming that because we are researchers, we may have questions, we may have answers, but we were always maintaining cultural sensitivities. We were looking at the values and issues that could harm or could be impeding the community engagement. We set priorities together. The community had questions. What is this virus? How can we identify which groups are most affected? What about potential for community health workers to be affected? What about their workload? Decision making, we had to look at power imbalances. We were not researchers coming from outside. Usually communities are at the bottom of making decisions in research. We tried to engage them in specific groups like women, children, differently abled people. We came together, and as a consensus, we conducted research in a rural setting that ensured that we did not exploit the vulnerable. We ensured equity, fairness. We tried. We looked at the needs of the community. We looked at issues of safety. We looked at issues globally and how it was affecting the community. So we went ahead. Stakeholder involvement, we were really excited. Things were coming up. Of course, as researchers, we were floating away with information, but community members were coming along with us as they also had their questions being answered. We had built trust, maybe not to the best level, but we had tried. And as we floated along, technical issues, ethical issues, issues of equity, we try to answer these. The power imbalances, community-based participatory research, we looked at these, we tried our best. As researchers, we did publish. As community health workers, they were able to take care of themselves. Thank you.
Thank you very much, Margaret. The next speaker is Emmanuel Makundi from Tanzania. Welcome.
We present ethical issues related to the engagement of marginalized and vulnerable groups in health research agenda in Tanzania. I'm coming from the National Institute for Medical Research in Tanzania. These are the Toga in northern part of Tanzania. I'm talking about priority setting research agenda. There will be a new review from 2027 to 2031, but for the previous agenda, 2013 to 18, marginalized groups were not engaged. So this time, we made sure for the first time that there was a chapter in the national agenda in Tanzania to make sure that disabled people and vulnerable groups were engaged. These people. These we start with case of albinism. In this particular year, these groups, they were killed for ritual purposes by belief for which doctors that you could be rich by killing them, but this has stopped. And who are the barbarics? There are very few people in northern Tanzania, and they keep goats and sheep. And who are Hadizabe? They live by hunting and gathering. Traditionally, they forage, hunting, berry, collection of honey in their areas. We used nominal group participatory technique, the public engagement technique, engaging simple writing discussion, display of results, and voting. Important is voting where how you see the power. Even if they're marginalized, they have power because there is a vote at the end of the session is voiced up. And then you see the nominal group technique is not being engaged anywhere in Tanzania to see that this voice is used in priority setting, and the findings were incorporated as a chapter in research agenda for the first time in Tanzania. So we see that we use the middle group technique in engaging both men and women, and there were the 4 stages, and I've mentioned, including 10 to 11 members in each group. And we include barbaric, physically disabled, people living with albinism and so on. And as I said, that for the first time, their results are included in the research agenda as a chapter. It's a chapter, and it is online. We could share with it that part. One challenge, this has not been evaluated. I will just present very fast the kind of research areas you find for women, physically disabled, HIV/AIDS, cancer of the joints. For the living with the albinism, skin of the cancer, cervical cancer, and impaired vision. This kind of thinking that for these people, these are priority issues relating to ethical issues, issue the power. You see, the researchers have power. We used nominal group technique, and we use associate people to reach these groups, but however, the power is still high. And then the other issue is how do we trade off between burden of disease and the needs of people like these? We have been talking of cancers, cervical issues, because if you use traditional issues, the burden of disease will feature, and these priorities will never be prioritized anywhere. In terms of conclusions and recommendations, engagement of these groups is legitimate, and to ensure financial resources, affirmative action is actually needed. Otherwise, these priorities will not be researched at all, and the use of normative frameworks such as FR, accountability for reasonable, including issues of transparency, use of evidence, but more important, when countries need to develop ethical guidelines for people living with disability for vulnerable groups, many countries do not have such guidelines. So there is a potential for exploitation. And thank you very much for your time and attention. Asante sana. Don't you school? Merci beaucoup. Welcome to the beautiful land of the Kilimanjaro, the Serengeti, the Zanzibar, the beautiful country, the land of Tanzania.
Thank you very much. So our next speaker is Daphne Maza from the Philippines. Welcome.
Okay, please start. So, good morning, everyone. I am Daphne Joyce Maza from the Philippine Council for Health Research and Development, also assigned as a Secretariat of the Philippine Health Research Ethics Board. So, today I will present on the ethics of the Philippine National Health Research System's 2017 to 2022 National Unified Health Research Agenda, or the NURA-3. So the Philippines has the NURA that provides the health research priorities in the country and is formulated and adopted by the PNHR, which is a framework anchored on the principles of essential national health research on inclusiveness, participation, quality, equity, efficiency, and effectiveness, operationalized by individuals and institutions involved in health research and development, specifically the core implementing agencies, which are the Department of Science and Technology, or through the PCHRD, the Department of Health, the University of the Philippines, Manila, National Institutes of Health, and the Commission on Higher Education. PCHRD is also the national coordinating body for health research and lead coordinator of the PNHRS. It provides administrative and technical support to the latter's governing council, steering committee, and the technical working committees, the RAMC, CBC, RUC, RESMOB, SOME, and FREB. So the Research Agenda Management Committee leads the development of the NURA and is tasked to provide technical and policy advice in formulating the research agenda for the present and future requirements of the country's health system. The NURA and the Regional Unified Health Research Agenda are used as strategic tools to direct research programs, funding priorities, and related activities. So in 2016, the RAMC pursued the development of a guideline for health research prioritization that was adopted in the development of the NURA-3. These guidelines provide for a comprehensive process of health research priority setting that includes a preparatory phase, an implementation phase, and a post-implementation phase. So to guarantee that the regional stakeholders are represented during the regional research priority setting workshops, the identification of participants at the regional level was given to the 17 RHRDCs, yielding a total of 387 stakeholder participants categorized as shown in this pie chart. Now, RHRDCs are typically composed of these member institutions. This means that consortia with fewer member institutions or smaller networks are limited in terms of engaging stakeholders that are non-members, especially these minority groups. As health research beneficiaries, it is important that their perspectives are heard and considered. So a proposed M&E plan was developed with the NURA 3, listing the performance indicators and next steps for the development of the NURA 4. The proposed M&E plan included the source of the performance indicators and the recommended timelines, which are annual monitoring, midterm evaluation in 2020, and final evaluation in 2022. Although the proposed M&E plan was sound and specific enough to monitor the dissemination, adoption, and uptake of NURA 3, the monitoring tool was not successfully pre-tested and rolled out, making data collection now challenging. Moreover, the scheduled midterm evaluation in 2020 was hindered due to the realignment of the national budget to respond to the COVID-19 pandemic, and almost all resources of the PNHRS were redirected to COVID-19 research, response, and economic aid. This means that not all of the NURA 3 research priority areas were equitably funded during the pandemic. As you can see, the NURA 3 identified 6 themes encompassing research priorities identified in the regional and national consultations. Based on the Ramsey Commission final evaluation of the NURA 3 in 2022, the most funded research fall under the themes of global competitiveness and innovation in health, research to enhance and extend lives, and health resiliency. So due to the COVID-19 pandemic, it is understandable that much of the limited resources for health research, especially PCHRD funds, were directed to these subtopics under global competitiveness and innovation in health and research to enhance and extend lives. However, monitoring reports would have been useful in informing the future actions and approaches of the PNHRS on how to equitably distribute available resources, especially to the priority areas which were underfunded or not funded at all, which are those 3. So given all of these, we make the recommendation to expand or increase the number of participants joining the national and regional research priority setting workshops and formulate a strong and harmonized M&E tool through inclusive regional and national consultations to guarantee that the identified research priorities are equitably funded and the benefits are distributed to all beneficiaries. Thank you very much.
Thank you very much. Thank you very much, Daphne. The next speaker is Wim Pinkston from Belgium. Welcome.
Okay, go. Good morning. A couple of years ago, together with some devoted colleagues, we built a value-oriented guidance tool for priority setting exercises. We were inspired by a Lancet series on setting priorities, but most on increasing value and reducing waste in biomedical research. Setting priorities is obviously a normatively laden process which touches upon what matters to us, our values. And the starting question in our research was whether priority setting exercises, as published in scientific literature, reflect the consideration of the values we claim to cherish. This cannot just be taken for granted. People generally do not make their values explicit or consider them systematically, even in reflexive processes like priority setting exercises. As such, assuming that all relevant values will at least implicitly be at the table when discussing priorities seems over-optimistic. Nevertheless, actively considering values is an essential task in ethical reflection. Gaining insight in the values of different stakeholders involved is important to avoid that personal interests, practical convenience, or coincidence take over, and to understand which ethical dilemmas deserve attention. When considering the values and the ethical dilemmas they generate, We need to establish complex equilibria. It would be unreasonable to overload individual research projects with excessive demands concerning the values we want them to realize. So important trade-offs will need to be made with a good sense of realism. This also applies to research priority setting, and together with Dana Hawash, Karla Shah, and other colleagues, we took nutrition research as a case study for this. We selected 22 manuscripts on the topic that we included in a scoping review. The selected studies cover a variety of research topics like obesity, wasting, stunting, malnutrition, different target population representing different ethnic and age groups, and priority setting methods like discussions, focus groups, Delphi, or Chinri. It soon became clear that most of the studies did not have an explicit or systematic way to consider values. This does not imply that values would be absent. In fact, each paper did refer to several values, but it was unclear whether the set of values that was considered was well chosen, coherent, or complete. This is exactly why we started developing a framework, a tool, building on the entire set of values that resonated in the selected paper. Extracting values with a team of researchers from very different disciplinary backgrounds was a true challenge, I can assure you, but in the end it worked out fine once we established shared understanding of all basic concepts. The extracted values were structured in 8 clusters: understanding, impact, feasibility, efficacy, equity, soundness, sustainability, and novelty. After extensive discussions, we reduced the 8 clusters to 3 main values: feasibility, impact, and accountability. First, we have feasibility, in which it is assessed whether research questions are answerable, realistic, and supported. Second is impact, which considers, for example, whether research is relevant, context-sensitive, or empowering. Third is accountability, which reflects, for example, on inclusiveness, cost-effectiveness, and sustainability. We realize that value extraction is a delicate enterprise. To calibrate our findings with the intention of authors, we invited first and last authors of the priority setting exercises to provide feedback on our tool. A number of them responded to our queries. Our tool does not assess the importance of specific values as such. In fact, it's completely up to the priority setters to determine their focus. The tool rather works as a lighthouse that does not tell you where to go, but enables you to position yourself in the landscape and to determine the course you want to take. This was also embedded in the design of the tool, in which the relevance of each value for the research project concerned can be indicated and discussed. It would thus be perfectly fine to favor some values over the other, be it after due consideration and in full transparency. In addition, we left the option open to add additional values. Summarized, our tool aims to trigger transparent, comprehensive, explicit, and open-ended reflection on which values can be adopted or forfeited, but not neglected. Besides, we want to create transparency of trade-offs that have been made. For those interested, more can be found in our paper. Thank you.
Thank you very much, Wim. Next speaker is Swalela Siddiq from Pakistan. Welcome.
You can start. Good morning. I will be speaking about conducting research on malnutrition over research communities in Pakistan. My presentation is titled Swaliha in Research Ethics, Land Down the Rabbit Hole. My journey into research ethics is much like Alice's descent down the rabbit hole. I draw experience as a teacher of ethics and my role as a reviewer of the National Bioethics Committee for Research. My story is set in Karachi, Pakistan. Karachi is a mega urban city of various contrasts and paradoxes as highlighted here. The top 3 pictures show tertiary care hospitals, whereas the bottom 3 illustrate health conditions and poverty rampant in peri-urban locations near Karachi, which is where my story will continue. The slide shows the map of Pakistan on the right. Karachi is located in the Sindh province, which is at a critical stage for malnutrition. My story centers on research conducted on malnutrition in specific communities within Karachi, which makes complete sense. A lot of research should be conducted since malnutrition continues to pose as a challenge. The issue, however, is when majority of research is conducted in a few locations by a few people. In the past 5 years, 12% of studies approved by NBC were on malnutrition. One private university featured in 50 of these studies, and 49 of these studies were conducted in these peri-urban locations. I argue that these are over-researched communities. Data from clinicaltrials.gov conducted that there were 25 malnutrition trials only in Karachi, and 9 of these were in peri-urban locations. Majority of them were on malnutrition supplements, some of which may not be available in these locations, creating issues of equity.
With poverty, disease, and lack of healthcare facilities makes it an attractive site for researchers. For the last 5 years, several NGOs and researchers from both community and clinical sciences have carried out different projects in the area.
And then I tumble further down the rabbit hole to 2023. While conducting a research ethics workshop, I showed the full movie in the previous slide. A participant shared a similar research is being conducted in the same location on the same topic. 25 years have passed, yet the study design, study topic, and study location remains the same. Which led me to ask, does the community want this? Where is the community? Where are their voices? On PubMed, keyword search for stakeholder engagement yielded 0 results. Diversifying the search led to 22 event results. Are these community being merely used as a means to an end? And how are they being used merely as a means to an end? Because domestic researchers benefit in various forms, but communities do not benefit. This represents a form of post-colonial legacy, with researchers exploiting marginalized and vulnerable populations for their own benefits. It reflects domestic injustice and persistent class inequities. Health research priority needs to contend that malnutrition is not only a health sector issue, but it deals with other sectors such as education, infrastructure, better transplant facilities. Funding clinical trials for nutritional supplements is insufficient. Also, limited interaction with government is also a huge problem. Research should ideally translate into policy, otherwise it is myopic. A major ethical issue is also the problem of governance. Despite a 3-tier research regulatory system in the country, clinical trials continue to be funded only on scientific merit, approved on technical merit. The outcome is persistent health inequities and inefficiencies because of lack of awareness about implementation research. So what should be done? It is important to address broader social determinants of health, to study malnutrition, not as a disease, but to figure out the problems in the health system. A recent article published in The Lancet considers decolonization of health research by hearing voices of community, considering tacit knowledge as opposed to only explicit knowledge. It is also important to hear voices of community by conducting experiential research on lived experiences of over-researched community which does not exist in Pakistan. IRBs should explicitly ask for detailed plan of engagement with government and ask for evidence of translation into policy as well. And for future health research policy setting now needs to consider changes on the climate. NBC recently reviewed a proposal to substitute a nutritional supplement in indigenous wheat grown in one of these over-researched communities. This has an impact on the biodiversity of the soil, and therefore this needs to be addressed. I end now with a quote from Alice in Wonderland. So would you tell me, please, which way I ought to go from here? Alice asks the cat. The cat signifies wisdom, acts as a guide. So I ask, which way do I ought to go from here? I hope that the GFBR will show me the way. Thank you.
Thank you very much. So our next speaker is Ivan Cesar from Ecuador. Please welcome. Yes, of course. Welcome.
Start, please. Good morning all. I am Ivan Sisa from Ecuador. Today I'm going to present results from an ongoing research project that is part of one of my research lines that I have been working on for the last decade regarding the contribution of Ecuadorian public universities to research on the main causes of mortality in my home country. Ecuador is a country located in northwestern South America. Its population is about 80 million inhabitants. Its main causes of mortality are non-communicable diseases such as ischemic heart disease, chronic kidney disease, and stroke. Furthermore, scientific research has not been a priority, thus its publication rate is among the lowest in the region. Our first experience trying to quantify Ecuadorian biomedical research and its relationship with the main burdens of disease goes back to 2011. In one decade, Ecuador produced 625 health science-related publications, and only 7% of this output was related to tackling the main causes of mortality. As a continuation of this previous research, we performed a second analysis, but this time with a larger period of time and assessing the impact of two public policy interventions, such as a new higher education law. We found an exponential rise in biomedical publications, but only 9% involved the primary causes of mortality. So how does Ecuador set its health research priorities? In 2010, using the recommendation of the Council of Health Research of Development and the Global Forum of Health Research, the Ministry of Health defined several health research priorities that included social determinants and diseases such as cardiovascular disease. Having this background and to provide more granular evidence to inform our health research policy, we set the following research questions. How has biomedical research evolved in Ecuador during the last century? Are Ecuadorian universities contributing to the solution of the main causes of mortality in the country? To answer these research questions, we use a bibliometric analysis. Bibliometry is the quantitative evaluation of scientific literature using prominent databases such as Scopus, Web of Science, or PubMed. Its applications include identifying gaps of research in a particular area or discipline. Scopus and Web of Science databases identify more than 14,000 publications based on the applied research equation. However, 3,225 publications fulfill the set inclusion criteria. The rest of the analysis and results based on this final sample size. The first scholar Ecuadorian publication that we were able to identify goes back to 1920 and studied yellow fever. We noticed a skyrocketing incrementation in the research output after the year 2000, most likely due to the implementation of this new higher education law in the country. The most prevalent research focus among the analyzed publications was clinical areas. We were surprised to find out that the main producer was private universities compared to public ones. Public universities are called to use tax money in an efficient, responsible, and ethical manner, which includes investing in research, of course. Regarding research lines, we found that Ecuadorian researchers published most in epidemiology and surveillance systems of diseases, followed by publication in diagnosis and treatment research and causes of diseases. On the other hand, public policy and early detection and prevention research lines were amongst the lowest rate. Only 12% of overall publications were dedicated to tackling main causes of Ecuadorian mortality. Further, out of this percentage, the principal producer was private universities compared to public universities. So, what are the reasons for this lower scientific output by public universities in Ecuador? Well, the answer is not easy since this issue has different ages. However, some reasons are politicization of Ecuadorian public universities, cumbersome bureaucracy that doesn't not allow using available resources efficiently, weak role of leadership of the Ecuadorian Ministry of Health, and lack of proper human resources with appropriate qualifications. To address this issue, it is imperative to remove politics from Ecuadorian public universities and build a national health research system among all key local stakeholders instead of continuing to work in a fragmented and isolated manner. In this way, institutions can foster a friendly environment for research in the country. I am Ivan Sisa from Universidad San Francisco de Quito in Ecuador. Thank you very much for your attention.
Thank you very much. Can I get some help, please? Okay, the next speaker is Benedict Weibong. Welcome, please, from Ghana.
You may start. Good morning, everyone. My name is Benedict Weibong from the School of Public Health, University of Ghana, and I'm here to share with you our thoughts on ethical vulnerabilities of research priorities setting using a case study upholding autonomy and beneficent research priorities and exercises in Ghana. My goal is really to provoke discussions on how to reverse the guilty verdict. Now, I'd say guilty verdict because most often, as it's already been said several in this room, that most often it's not the brightest of ideas that get prioritized. And this is because the default is to approach research priority setting as a technical issue and not an ethical issue. Well, I say this with confidence because the numbers do not lie. This is true. In Ghana, 13 out of the 31 individuals we approached thought that research priority setting is a technical issue. Unfortunately, these and many others are more likely to take the rather uncompromising position, such as, this is my decision, when they are faced with the challenge of the use of scarce resources. Talking about scarce resources, this is an important trigger of the ethical vulnerabilities associated with the process of research priority setting, because we all know too well that he who pays the piper calls the tune. These vulnerabilities are particularly more pronounced in the field of mental health and disability research, where there are known disparities. And in Ghana, we know that less than 1% of total GDP is spent on research. The implications of these are that because the field is relatively underfunded, it's a sensible thing then to prioritize research priorities. But we also know that this also leaves room for vulnerabilities. And that is why it's important that research priority setting must be immersed in the colors of ethical imperativeness. Because we need to try to think about protecting of good cause. And there are three key reasons why it's important to set research priorities within this scope. The true definition of priority setting reveals very clearly a number of ethical dimensions. Human research participants must benefit from the research. But what we do know that most funders always do not look at what outcomes are important to patients. I think this is clearly reasons why we are in a guilty verdict. But there is a way to reverse this. One way is to uphold autonomy and beneficence in research priority settings. The road sometimes might look long and lonely, but it's always important to do the right thing. Who knows? One day you may just see the light of a bright side of a research priority setting exercise. I will now want to share with you how we did this in Ghana by sharing with you our role or our goal of setting research priorities for mental health and disability research. Here I will demonstrate two key ethical principles that we all know too well: upholding autonomy. In our study, what we did was we ensured a careful selection and inclusion of experts based on existing local directory. What we also did that was very important was that we did not go with preconceived list of priority research areas, but instead we requested them to come out with their own organically developed research priority areas. Also, when we continue in our bid to ensure autonomy, we went ahead to engage the community to ensure that there was clear community ownership through validation workshops after we collected our data. And in our survey, we included timelines to ensure that they had the role to tell when they would think that this research should be done. In terms of beneficence, what we did was that we employed methodologies that reflect context and the specific needs, because the goals of what can always be influenced by what you see, depending on where you are standing. And we did this using a rapid review. We also adopted the Child Nutrition Research Initiative strategy. But you know what? All this, it wasn't all that rosy because there were still some issues. We had only 58% response rate. It was very, very challenging to include mental health persons with mental health conditions who are the direct beneficiaries of this. And in our bid to cut down on the numbers that we were getting, we pruned the research questions, and this must have dampened the voices and the goals of people who should be heard. But we still had some lessons. The three key lessons that we came out with, that we must be deliberate in our effort. We have to use proven methodologies. And very, very importantly, we have to uphold context and ensure that context reflects in our research priority setting exercises. in conclusion, I just want to say that it is feasible that to employ a systematic methodology to do this and to uphold the ethical principles of autonomy and beneficence. In these, it is very possible to reverse this guilty verdict, if only we as researchers and ethics committees try to play a shared role. I'd want to end by acknowledging the funders, UK Aid, and my colleagues from the University of Ghana, King's College London, and the Ghana Participation Program for their participation in this work. I thank you sincerely for your attention.
Thank you very much, Benedict. And thank you all for a very, very excellent session.